Good morning. Welcome everyone, our in-person attendees and those joining us on C-SPAN this morning. We have a very exciting program for you over the next 90 minutes. I am Brian Blaze, the president of Paragon Health Institute. Paragon is a health policy research center with a mission of empowering patients and reforming government. We use economic reasoning and evidence-based research to critically evaluate health policies and make policy recommendations. I'm going to start with a lot of thank yous for this event coming together today. First, I want to thank the secretaries, Kathleen Sebelius and Alex Azar, former secretaries of the Department of Health and Human Services, for their time, their expertise, and their leadership. It was really their joint op-ed in STAT making a powerful case for Medicare site-neutral payments, which is why we've been able to put this event together. So thank you, secretaries. After I read their op-ed, I contacted Lauren Adler at the Brookings Institution about the idea of a joint event with the secretaries. This is before the secretaries knew about this. To highlight an important area of policy agreement, across the policy community. He agreed and suggested broadening the coalition to include the Center for American Progress and the American Enterprise Institute. We contacted policy experts at each of those organizations, and they enthusiastically agreed to participate. So thank you to Lauren, Andrea Dukas at CAP, and Ben Ippolito at AEI, who are going to join us today and participate on our second panel. They're going to join my colleague at Paragon, Joe Albanese, and that panel will be moderated by STAT's Rachel Kors-Zhang. Today's discussion will feature an area of strong bipartisan agreement. Medicare payments should be the same for services that can be safely and effectively provided in hospital outpatient departments, ambulatory surgical centers, and physician offices. Typically, they are much higher when provided in hospitals. Medicare site-neutral payments would mean lower costs for patients and taxpayers, and Medicare site-neutral payments would reduce the incentive that hospitals have to acquire physician practices, acquisition which has been shown to raise commercial health prices. Today we'll explore both the case for Medicare site-neutral payments and considerations for how to overcome opposition. I want to thank Arnold Ventures, which provided financial support to make today's event possible, and to the Paragon team for their work in putting today's event together. During the panels, we were aimed to incorporate questions from in-person attendees as well as C-SPAN viewers. If you have a question, you can text it to, and this number is on the banners, 703-527-2734. And if you're in the room, you could also use the QR code on the banners. Now, let me introduce the secretaries. First, Kathleen Sebelius served as the 21st HHS Secretary from 2009 through 2014. She was previously elected statewide in Kansas 4 times, twice as insurance commissioner and twice as governor. She had many accomplishments as secretary, including the passage of the Affordable Care Act and its early implementation. She continues her policy work with KFF, co-leads Health Strategy Group for the Aspen Institute, and serves on numerous corporate boards. And to her left, Alex Azar served as the 24th...
Barely to my left.
You're both to my left today. Alex Azar served as the 24th HHS Secretary from 2018 to 2021. Secretary Azar had many accomplishments as Secretary, but above all, he deserves enormous credit for the success of Operation Warp Speed, which delivered COVID-19 vaccines and therapeutics in record time. He is currently an adjunct professor at the University of Miami, is involved with numerous policy organizations, including the Bipartisan Policy Center's Future of Healthcare Advisory Group, and he serves on numerous corporate boards. Please join me in welcoming Secretary Sebelius and Azar. So we'll start with Secretary Sebelius and then go to Secretary Azar. Can you just start and talk about the importance of this issue? And you have a joint op-ed, sort of the why you chose this issue to do a joint op-ed.
Well, thank you, Brian, first of all, for organizing this. And I think the phrase that you used, a strong bipartisan support, is an unusual phrase to use in this town. And I think that highlights one of the reasons that both Alex and I decided that this made a good topic to highlight. During at least my tenure at HHS and during the Obama administration, we continued to try and identify ways. I mean, one of the goals was the so-called triple aim: right care to the right patient at the right time, lowering costs but not decreasing benefits, and improving the quality of overall health care, including population health care. So that was sort of the magic North Star. And with the Affordable Care Act, there was a real effort to bring down overall costs of Medicare and improve some of the quality outcomes. And this became an early space to do that, where it was identified that if you were paying differentially for care and the quality didn't improve, all you were doing is layering additional costs on beneficiaries, increasing the overall cost of the program, without improving quality for anybody. And so it became one of the targets in the overall Medicare savings, how you really improve lives of beneficiaries without decreasing the benefits that they are eligible for. And so I would say in the early budget discussions, unfortunately, it was not included in a budget until 2015, when it finally became part of the Balanced Budget Act of 2015. But it was always one of the targets that was put on the table, talked about, pushed forward, along with a host of other programs, and made just really good sense that why pay for a differential in care prices if the care that was delivered was the same, because all that did is layer costs onto beneficiaries in the overall program. So that target fit very neatly into the North Star of the triple aim, and was on the table from, I would say, the very beginning, with some very strong opposition.
Same. So first, want to thank Secretary Sebelius. Always great to be with her on a panel, and want to thank Brian and Paragon. Paragon's doing just incredible work with market-based thinking about healthcare. So thank you, Brian, for all that you do. With regard to this op-ed, I'd say Secretary Sebelius and I and Secretary Shalala and I look for opportunities where we can strike out and show that you can be from very different ideological perspectives, but there's a lot in healthcare that we can agree upon. I think for the country, it's good to see that we actually get along. We're friends. We agree on a lot. There's a lot we disagree about. We wrote, I think our initial op-ed was on the nursing shortage. We co-authored a piece calling for relieving some of the visa caps on foreign-trained nurses to deal with the nursing shortage. And just about a week and a half ago, Secretary Shulkin coordinated an op-ed calling for Operation Warp Speed on cybersecurity that the Secretary and I were both part of a group of 9 bipartisan VA and HHS secretaries.
Cybersecurity in the health space.
In the health space, sorry, yes, in the health space. Why site neutral? So I have been very, very passionate about the issue of site neutral payments, probably an odd issue to be passionate about, but I'm very passionate about it. As with so much in healthcare, a lot comes from personal experiences in the system. And I had an episode where, after I had been Deputy Secretary of HHS, I'm in Indianapolis, I'm a senior executive at Eli Lilly, I'm under the care, I've got a cardiologist, and there's a medicine, mild medicine I was taking, I didn't want to take it anymore, I'm in with my cardiologist, and I say, hey, can we stop this med? And he says, yeah, sure, but I'd like to do an echocardio stress test first, just to make sure we get a good baseline, everything's good. I said, okay, great. He said, can you do it now? I said, yeah, I can do it now. He said, okay, let's take care of it. So his nurse grabs me, and I figure we're just going to walk, to the room next door, and I'll hop on a treadmill and get some echoes done. And instead, we're going to the elevator. We get on the elevator, and then pretty soon we're walking through a tunnel. You know those ugly subway-like tunnels with the yellowish kind of bricks? And we're in one of these old tunnels. We keep marching along, and I'm just getting more and more suspicious.
That is the stress test.
Yeah, exactly. And then we sit down at a desk, and there's a woman there, and she's got a computer. Name, social security number, date of birth, address, insurance. And pretty soon she slapped one of those plastic wristbands on me. And I'm like, what the heck is going on here? I've just been admitted to a hospital. And then the nurse marches me over, and I find I'm in the cardiac lab. I'm like literally where people are being wheeled in with heart attacks, like to get stents and everything. And I'm sitting there, and I've got a high deductible plan at Lilly, and so I'm going to be eating this, whatever the cost is of this, because I'm still at the beginning of my deductible. So fortunately, I hadn't just fallen off the turnip truck, having been deputy secretary of HHS and a top executive at Lilly. And so I go up to the desk and I say, hey, how much is it going to cost? Because I knew about site of care differentials. How much is it going to cost me? We can't tell you. I said, well, get me a manager, because someone needs to tell me. Manager comes out. I say, how much is this going to cost me? We can't tell you. I'm like, what do you mean you can't tell me? Well, we can't tell you. I said, well, you know what you're going to charge me? Yes. But we can't tell you. I said, well, all right, here's the story. Former deputy secretary of HHS, top executive at Lilly. Tomorrow there's going to be an op-ed in the Wall Street Journal about this experience if you don't tell me. Okay. It's $5,500. And so fortunately I got on my phone, and Harvard Pilgrim at the time had a great little website where you could see what things should cost, and went there. And it cost exactly what I thought. About $550 is what an echocardiostress ought to cost. And so I said, all right, so $5,500. What does my insurance get me by way of a discount? Well, we can't tell you that. I said, okay, here we go again. Former deputy secretary, executive at Lilly, Wall Street Journal. Well, we can't tell you what your negotiated discount is with Anthem, but if you were to pay cash, let's just say it's $3,200. And I say, so let me get this straight. I could fly with my wife first class back to Washington, D.C., stay in a suite at the Four Seasons for the weekend, see my cardiologist on K Street, who was George H.W. Bush's cardiologist, get the echocardiostress stress test done in his office where it would be done, fly back after a great weekend, and you could get the results sent in, and I would still make money compared to having it done here. And that's the experience of American healthcare. And that is why I am so passionate about site of care differentials and getting to site neutrality. It is such a distortion in the system. It leads to consolidation in the system. It is inefficient, and it's bad for patients.
And probably led to your support and implementation of the price transparency rules, too.
It absolutely was part of that.
So let's press a little bit on the bipartisan nature of this, because we have a lot of disagreements in the health policy community, but here, and I think with the organizations co-sponsoring this event, there's a lot of bipartisan agreement. Maybe Secretary Sebelius, you could talk about what particularly appeals to Democrats and your experiences in the Obama administration. And then Secretary Azar, you can do the same with the Trump administration. And in particular, President Trump had the commitment that there would be no cuts to Medicare under his watch, yet there was a significant expansion of the site-neutral payments that had started in the Obama administration and the Trump administration.
Well, I have not had the personal experience that Secretary Azar talks about, but know enough about the whole experience in healthcare that there are lots of things that make no sense, and there are lots of things that we overpay for on and on and on again. That have ferocious allies that basically can make a very compelling case to members of Congress so nothing happens. The policy change may make good sense, but by the time it gets through Congress with individual members who are told about the ills that will befall their constituents, the easier pathway is do nothing. The default is always do nothing. When new things are added, rather than getting rid of old things, we continue to do the old things and then layer on the new things. That's why costs continue to rise and almost never go down. So I think that, we started with a philosophy, as I say, not just on the North Star of the triple aim, but also because the Affordable Care Act included a measured reduction in what was being paid to Medicare Advantage plans, it gave us an opportunity to look across the board at Medicare costs. And the whole structure of the MA plan was to set a ceiling with fee-for-service plans. MA came into the marketplace in the 90s with the promise that we will deliver the same benefits. Let industry participate, let industry compete. We'll deliver the same benefits at 90% of the cost. 90%. By the time President Obama was elected in 2009, when the first measurement was made, MA plans were delivering the same benefits at 110% of the cost. So it was a swing of about 20 points, if you will, from what the promise had been, what competition would do, and what was actually happening. So there was a look in the Obama administration just across the board, and a very intense look at where particularly pricing made no sense, where the cost was falling on beneficiaries and delivering no increase in quality, where we could look, and it was everything from drugs to, bundled payments to site-neutral payments and on, knowing that each of those was probably going to be a pretty ferocious battle, but they were worth, putting on the table, beginning the education of the public, because anytime you go anywhere near Medicare, the accusation of the status quo allies is always you're cutting benefits for seniors. That's very difficult to overcome. It's very difficult to translate. The sooner that you have to get into a conversation about, well, this really doesn't cut it, it just shifts it, blah, blah, blah. I mean, you've already lost the argument, right? So this is one case in point where site-neutral payments made perfectly good sense. By the time that concept gets into the Balanced Budget Act, it was honed down with exemptions and phased-in policies and, start and stop issues to the point that it affected about 1% of the overall payments for the qualities of service that were being delivered. And it just was a great example of how a thoughtful concept saying we should pay the same amount if you're getting an exam, if you're getting a shot, if you're having a drug infusion, whatever, it should be paid the same, whether it's in a doctor's office or in an ambulatory surgical center or in a hospital. Same treatment, same cost, right? Very simple. Gets translated into a very narrow band of services in a phased-in approach with lots of exemptions. And so we started the path, but it was a long way from being delivered fully in the 2015 Balanced Budget Act. But people within the agency, people knowledgeable about the system, and a lot of physicians were very enthusiastic about this, but the hospitals, I would say, were wildly unenthusiastic and managed to negotiate through that process for a very narrow application of the concept. And so the baton then was passed to the next administration.
I mean, I'd say site neutrality is one of those issues that is probably more policy wonky, technocratic, and not terribly ideological in healthcare among those of us who deal with the economics of healthcare. It's a legacy coming out of how we did Medicare fee-for-service that originally, up until the late 80s, early 90s, we paid based on a provider's usual and customary rates. And then we said, well, that's out of control, so we create fee schedules. And what's the easiest thing to do? You freeze in place the current fees. So hospitals charging more than doctors' offices for doing the same thing. You lock it in place with these fee schedules, and once it's there, it becomes an entitlement. And as the Secretary just talked about, the hospitals certainly don't want to give that up. I'd say ideologically, in terms of, say, the Trump administration and a focus on this, first, there is the savings. We've got to find ways to save money in Medicare. Secondly, though, I think it gets to an idea of regulating the what and not the how. That you see, whether it was an approach to Medicare Advantage or as we did in CMMI, direct contracting with total cost of care capitation, saying here is an amount of money, Now figure it out. Have flexibility in the system. Now you figure out how to deliver on that. So if it makes sense to do it at an ambulatory surgical center, do it there. If it makes sense to be at a hospital, do it there. But here's what we are going to pay. And I'd say, I think we probably would very much agree, a concern about this artificial arbitrage incentive to integration and consolidation. We're very nervous about just how hard it is for independent physician practices to remain independent, and they're getting gobbled up by these big hospital systems. And when you create a massive arbitrage opportunity by simply being acquired to make a lot more money, what do you think is going to happen? Yeah, my theme when I teach down at Miami is always, no matter what you think about healthcare, equity, moral right, whatever else, if you fail to understand that healthcare goods are economic goods and will follow economic laws, you will be sadly mistaken. And this would be an instance.
So just to recap, the Balanced Budget Act, site-neutral payments for off-campus hospitals, but they had to be billing after November 2nd, 2015, and there were several exemptions. And then the Trump administration...
And limited number of services that it applied to. Yeah.
And then the Trump administration expanded it and got rid of the exemption. And that was challenged by the hospitals. And how did that work out in the courts, Mr. Secretary?
On the legal challenge, what, Brian, tell me? I actually don't remember I assume we lost.
We won.
Did we win that one?
Trump
Okay,
administration won.
Usually we lost.
Yep.
But we did the normalization on clinic visits, and we did some normalizing payment rates on ASCs versus outpatient hospital facilities. I got rid of the inpatient only rule, which I didn't even know about. I was sitting there with the CMS administrator, and she's walking me through some tweaks and changes to the annual payment reg on the inpatient prospective payment system regulation, and is saying, well, and we're going to take these procedures off of the inpatient only rule. And I said, what? What is that? I've been around a while, but I had never heard of this inpatient only rule. Well, it's where we tell hospitals that only they can provide a certain type of procedure. I said, why the devil do we do that? Like, what business do we have saying that something can only be done in one place? Like, what does someone on Security Boulevard up in Baltimore know better than doctors and hospitals and medical practitioners about what to do? So I said, get rid of it. He was like, what? I said, just get rid of it. So we actually got rid of the inpatient only rule in its entirety, and said, essentially, the system will work out where things ought to happen. The new administration came in and actually restored the inpatient-only rules, at least in part. But I think, listen, the hospitals like it. So hospitals are a big constituency, and as we've talked about, going up against the hospitals is a challenge.
Difficult.
So you mentioned the harms with these site differential payments leading to consolidation. And we know that consolidation raises prices in the commercial sector. We also know that a lot of private payers benchmark what they pay to Medicare. So these problems with Medicare payments get amplified in the private sector. Now, it's clear that site-neutral payments lower costs for patients and taxpayers, but I'd like to talk about quality of care. There's concerns raised by hospitals that if you take some of these services out of the hospitals, patients will experience lower quality of care.
Well, I would say, Brian, that there is, to my knowledge, not an iota of evidence that backs up the lower quality. Let's just start there. And Secretary Azar and I were talking earlier about hospitals, and particularly hospitals right now with the staffing shortage that's throughout healthcare are not only not terribly safe places to be, but sometimes dangerous places to be. If you're on a holiday weekend or a night shift, the number of medication errors or possibilities of somebody falling or not getting care in a timely fashion is just increased because there are really severe staff shortages. And so I think that whatever the argument was about care quality being diminished have really been flipped. I think you could make a very compelling case just on the site itself that being out of a hospital to get a treatment that can be safely administered in a physician office or in a outpatient clinic is better than being inside a hospital setting. That's step one. But step two, I think, is really the consolidation issue and the number of private practices who have been acquired by big hospital systems and vertically integrated, horizontally integrated, has done a dramatic, is accounting for a dramatic increase in prices. It's one of the few industries where consolidation and qualities of scale haven't lowered prices, they've increased prices. The ability to charge more and really have a more monopolistic ability to negotiate a rate that is higher is very, again, easily demonstrated by the economic trends. And having a payment system that actually provides incentives for acquisition, incentives for consolidation, instead of discouraging it, which is one of the things that price neutral, site neutral pricing would do, I think is actually moving in the wrong direction. Overall, the consolidation will raise costs. The patient is, I would say, not is adversely impacted not just by the prices that they're going to pay in the long run, by the deductibles that go up, by the amount of fee-for-service increases that they're going to be, but also in just overall quality delivery. There is no evidence at all, and in fact, I would say reverse evidence at this point, that being in a hospital is the best place to be for any kind of treatment which isn't required to have that hospital care.
And Brian, I would just add that the hospital's argument, it proves too much. Because if it's unsafe to do a procedure at an ambulatory surgical center, then it shouldn't be happening there. This is about how much you pay at each place. Paying more to the hospital doesn't make the hospital safer. You could fight with me about my views on the inpatient-only rule if your concern is about safety in those particular codes. I disagree, but we could have an argument about that. But on site neutrality, then you shouldn't be paying for them at all if you view that as unsafe to be happening there.
So I love the last sentence in your op-ed. To remind you, the last sentence, you conclude, it's a no-brainer that we believe could reduce costs for patients and payers. Of course, we've talked, it's not a no-brainer for everyone. We've got a powerful interest, hospitals that are on the other side. How do you recommend that policymakers tackle this issue with the hospitals? And are there any issues that the hospitals raise about moving to site-neutral payments that you give credence to?
Listen, the bigger argument for hospitals is just the overall business model. Listen, they are, in spite of the so-called nonprofit hospitals and how some of them behave, they are low-margin businesses, and they are heavily regulated, and that regulation is oftentimes unnecessary, overly burdensome, and it increases artificially their cost structures. The way to solve that is by addressing those issues, not by artificially subsidizing them through a payment system that distorts all the rest of healthcare, though, would be there. So I'd say, yes, there's a challenge, especially rural hospitals, inner-city hospitals. There's a challenge with the fundamental business model of hospitals, but we don't solve that with these types of distortions. I think, I'm not sure you're going to get the hospitals to agree. Honestly, I think the way this happens, by legislation, is going to be when you have a must-pass vehicle, like a reconciliation package. Let's say, if there's a Republican sweep of the Congress and the presidency, and you've got the Trump tax cuts that have to be renewed, site-neutral payments could easily be a pay-for in there that throws money in. If there's a President Harris and a Democratic Congress, there could be some new initiative that requires money, and again, a pay-for. I doubt site-neutral, even with the two of us being supportive of it, ever passes as a standalone, but I think it could be a nice funding source.
It will never, I'll be a little bolder than my secretary colleague, it will never pass as a standalone, I don't believe, because at that point you get very strong local pressure. But I would agree with Secretary Azar that the hospital cost situation, particularly rural hospitals and to some extent, dense urban centers, does have a an overall economic challenge, and that needs to be addressed. And coming out of a very rural state like Kansas, what I know is if you close a hospital, you close the town, because people will not live in a community where you say it's a lovely place and you got a great school, but you have to drive 60 miles for healthcare. Rural communities in my state and across the country are getting older and poorer. So a hospital and hospital-like services are really important. It doesn't mean that every hospital in every rural community has to have the complete range of all services, be ready to do heart transplants and, complicated care. But rural communities also have a real problem with healthcare providers, separate doctors' offices, physician assistant clinics. This change could actually increase healthcare access in rural areas. It could encourage, with a payment structure that flipped, and give an independent doctor's office, a nurse practitioner clinic, the ability to administer chemotherapy treatments, do all kinds of things that people want much closer to home. They don't really want to have to travel to a hospital to get it. They want, care and treatment as close to home base as possible. So I think not only does it not, it won't hinder or help the overall payment scheme for rural hospitals, but it could increase access to health care in rural communities. I also agree that hopefully this and a range of other things could be part of an overall budget reconciliation plan, because there are lots of savings. This is one of them. Bundled care accelerated in a dramatic way is another one. I mean, there are lots of areas where I think there is a lot of policy bipartisan agreement, but lots of folks inside the special interest groups, the industry, who will resist it. So in some ways, packaging them together as a pay for is one of the things that I hope would happen. So not just this area, but looking across the board at what really does lower costs without limiting benefits. I think that's critical. To bring a lot of the folks who really don't want to tamper with Medicare benefits, you need to have that as part of it. We've got a lot of quality studies and we have a lot of agreement. So there could be a substantial, this in and of itself, they say could be as high as $200 billion in savings. And if you add chemotherapy and some exams and some treatments, it goes even higher. So this is real money. That could be not only savings for beneficiaries because they're paying deductibles and out-of-pocket costs and various other things, but it also could really extend the life of the Medicare program, and packaged that way with a number of other changes. I think there's a real shot at getting some things done, whether it's a Democratic or Republican administration.
And there are, I think that's very well said, and there's a lot of programs that subsidize hospitals. There we have DISH, we have Medicaid supplemental payments, we have state-directed payments. Yeah, so it's like take away one of the least efficient ways to subsidize hospitals that has all these other adverse effects in the health sector.
But I would tell you that, and I think Secretary Azar and those of you in the room probably know this very well, that the hospitals also have extraordinary fixed costs, and one of the fixed costs is the machines, the testing machine, the MRI machine, and the echocardiogram, and that need to keep running. And one of the acquisition of doctors' practices is to keep those testing mechanisms running, because it's part of the overall payment scheme that will help keep that. And so I think looking at all of the structure of what's required to keep beds in communities across the country, and some expertise at the hospital level, what can be regionalized in terms of advanced treatment testing, is part of what needs to happen across the board with rural healthcare.
Any particular feedback you want to share from independent physician offices on site-neutral payments?
Well, I live in a community, Lawrence, Kansas, so the university is there. We have a local community hospital, And I can tell you they are busily trying to acquire independent practices. I have talked to a number of the physician friends who say a lot of the government policies make their lives more difficult. That they know if they, and in our community, the hospital and where a lot of the doctor suites are literally a block apart. So it is not it's not tunneled the same way that Secretary Azar, but it's a very close proximity. So these docs say to me, look at this. I could, spit at the emergency room, and they are getting, 50% more, 100% more, 150% more to deliver this service than I am, and they make that part of the deal. You come and join us, and here is how your salary, your overall cost will increase. And oh, by the way, we'd love access to your patients so we could give them the opportunity to make available this whole range of services. So it's a very real conversation, and it's one that is very discouraging, I think, to the remaining independent docs who are saying, the world is tilted against us delivering the best care at the lowest cost because we're being squeezed to the point it's really tough to do.
Let me ask a question from the audience, and I think President Obama was very articulate in the challenges that Medicare presented from a fiscal perspective, and I think the current debate has gotten away from that. How do you view the fiscal situation? I mean, you were both trustees for Social Security and Medicare. The fiscal challenges that Social Security and Medicare have with sort of the imperative for policymakers to act sooner rather than later with all the political conversation going on.
I think part of the challenge, you didn't phrase it exactly this way, but when people give guarantees or make statements like there will be no cuts to Medicare, I think it depends what that means. Because of course you're always rebalancing. Every payment regulation you put out is a rebalancing of payments. A little, cutting something here, raising something there. I mean, Brian, you've read through these thousands of pages of regulations before. So we have to address these issues. What we have to do, and probably Secretary Sebelius and I agree on this, is we need to do it in a way that doesn't harm beneficiaries and harm their access, harm their benefit packages. And there are ways to do that. And frankly, I think what happens, I'm probably a bit less dire in my predictions about the solvency of Medicare than others because there's a lot of money in them there hills. And if all you really have to do is look at Obama, Trump, and Biden OMB budgets, and the menu's there. They put their wish list in of different areas where there's a lot of fat and where it's just needing the political will to overcome it to reap that money. And then we'll get a reconciliation package at some point, which is an expedited vehicle to get through Congress. And it'll become a grab bag of all those old things that have been socialized over the last decade. And we'll buy ourselves another decade or something.
I don't disagree with anything the Secretary just said. I do think, though, the forward-facing politics, talking to the American public, and the internal dialogue among policymakers and the folks who know how these budgets work, both are really important. So we faced a situation when the Affordable Care Act was passed. We had a 4-year, 3.5, but who's counting, implementation gap between the time the president signed the law in March of 2010. It didn't go fully into effect until January of 2014. And in the meantime, there was a deluge of misinformation about what was going to happen. Up to, I was running death panels and you would lose your firstborn child and a whole series of things that were hard to combat because it was all he said, she said. One of the issues was that the framework for this reduction in overall cost to Medicare Advantage would destroy the program. That was said over and over and over again. This is the death of Medicare Advantage. You like the choice you have. It's going to go away. Well, nothing about that was accurate. In fact, Medicare Advantage is significantly more beneficial and stronger than it's ever been. More beneficiaries are choosing it. The costs have come down to mirror a bit more fee-for-service. They're at about 103%. The last time I looked, not 119%. But it was a good example of what is being told to people, and nobody wants to lose their health care. Health care is by far the most important and personal benefit anybody will ever have. And any conversation that starts with saying you will lose this, but take my word for it, it's going to be better, is a non-starter. I mean, we learned that in Harry and Louise. We learned it over and over again. You tell people, and I would say the Republicans were 100% correct about allowing the Affordable Care Act to start meant that it could never be taken away. Because once people actually engaged with the benefits, once folks understood what exactly was going to happen, it has been impossible to stop the program. And I think having a conversation with the American public, particularly around Medicare, about you will not lose a single benefit. That has to be the beginning of every conversation. Here are the guaranteed benefits. You will continue to have the guaranteed benefits. Here, we talk about it often from the cost point of view. People don't want to know about costs because they don't know what anything costs anyway, and no one will tell them. Even the secretary and the former Lilly exec can't get a cost. Nobody can get a cost. And if you ever have looked at a bill that comes from a hospital saying, this is really not a bill, this is, I mean, none of it makes any sense. So cost is blurry-eyed to people. What they want to know is they will not lose a benefit. That has to be said 100,000 times. But I would agree with Secretary Azar. There is a lot of cutting things by 1%, lowering costs in this area by 1% or 2%, given the number of Medicare beneficiaries, is a huge pot of money. When the Affordable Care Act increased the lifetime of the Medicare Trust Fund by about 12 years. That's big money. That was in one shift. So that money is throughout the budgets, and it is relatively easy to identify. And you can sell it, I think, if you remind people 100,000 times that they will not lose a benefit. They will have some options that they didn't have before, and it will increase payment to their doctors, which folks, I think, would like a lot.
And that sounds like the message that you could take to whoever the next president is, to tell them, if you're briefing them, to build support for this. It's not going to cut benefits. It's going to save beneficiaries money. It's going to save taxpayers money, and it's going to reduce harmful consolidation.
Well, again, the internal conversation has to be different. As somebody who ran for office, the conversation with the public has to be very simple, very straightforward, and start with, you will not lose anything. Here are the benefits guaranteed. They will continue to be guaranteed, not we'll make these cuts and costs and, it won't. I mean, as soon as people hear cut, they think, no, that's not good for me. So it really has to be, I think, a very political campaign to the outside, truthful, political messaging, very simple, but it starts with you don't lose benefits.
Secretary, is there any closing thoughts from you?
No, just I think what you're seeing here is that we can actually, despite political parties or broad ideologies, agree on very important, very big parts of how our healthcare system can be made better, made more efficient, made more patient-centric. And I hope that's reassuring to people who live in the world where there's so much conflict out there, to see that that in our world of healthcare policy there are a lot of commonalities that hopefully we can actually make progress on implementing. Thank you for hosting this.
Thank you. We look forward to your next op-ed, and maybe we'll do another event. Everyone, please join me in thanking Secretary Sebelius and Azar.